So the thing that we are going to talk about here is something that's very close to what I do every day, which is remote monitoring and tele ICUs. A brief disclosure on what I do. It's part of my CV, so we'll proceed with full disclosure. Since this was intended as a basic course, Professor had mentioned that we're going to talk about more advanced concepts later. One of the key premises that we should understand is something called the concept of the healthcare iron triangle. And this is what actually enhances the value of tele ICU and telemedicine services in general, which is that in healthcare, it is very difficult to give high quality with universal access at low cost. So the challenge here is that technology is the one tool that we all look at, which is capable of breaking this iron triangle and allows you to provide health, value, and equitable health to a population at large using the tool wisely. So one of the earlier speakers were talking about different models of tele ICU and telemedicine in general. And the model that I'm going to focus on is the model that we look at from the RMP to RMP model, which is a doctor supporting another doctor through telemedicine, and that doctor on the spoke site then helps the patient. So since this is a basic lecture, we will initially be talking about these things. However, so much has been talked about telemedicine technologies in general that I think some of this is actually already commonplace. So there are device-based models out there that augment telemedicine, and this has been discussed and will be discussed in multiple directions during the course of these educational series, that I would just want to iterate that people should know about this. We can go into details and how advanced these things can get over time. Going into specifically the tele ICU part, intensivists have been the most critical piece of outcomes related to critical care, because a closed ICU model that involves an intensivist-led functioning of the ICU has been shown to be associated with improved outcomes over the past few decades. So some of this doesn't need to be revisited, but what is critical and key is that India has a huge shortage in trained intensivists. So by trained intensivists, you would mean somebody who has done an MD in medicine or anesthesia and then go on to do a fellowship in critical care. US has a big shortage, but you can see how massive the shortage is in the Indian space. And the solution typically is technology in the form of a hub and spoke model that has been addressed in multiple fora. But in the US, for example, you're able to take care of 100 to 160 patients as part of a hub and spoke network. Whereas in India, these models are still maturing, and they are maturing mainly because of the bedside availability of technological flexibility, which we can go into detail subsequently. But this telemedicine on steroids, or a supercharged form of telemedicine, which you would call as a tele ICU or a smart ICU system, is what makes this happen. So this is from our center. The spoke hospital is in rural Bihar, where we connect using our technology and are able to take care of this patient. This was pre-COVID, where you can see the patient is not in the caregiver is not in a PPE, but the idea was that this was the first patient that this hospital was able to do prone ventilation on, and that was due to real-time pervasive support of the tele ICU system that allowed them to carry on with this level of expertise. So some of the key features of a tele ICU system is that you need exquisite high quality videos, because you can get monitor streams, you can get data coming through connected monitors, but what is critically important in a tele ICU is you should be able to see the patient, you should be able to look at the tracings, you should be able to look at the personnel, you should be able to look at the tip of the needle and guide the bedside team during key life-saving procedures. So it's extremely important to have high quality video. And this is an example that I'm bringing to you from a very remote part of the country, top 5 most under served districts in India, Motihari district in East Champaran. You can see that even with the current technology on bandwidth that we have, today in India, it's actually possible to give you 1080p video that allows the tele ICU team based out of Bangalore to remotely help with the care of the patient. So our nurses, for example, can look at precise even text on the medication, so that we can help the bedside team with minute-to-minute changes, how to titrate drips, how to mix medications that are critical, how to look at the settings very, very closely, as you can see here. So a brief layout of the command centers: you have a critical care nurse and an intensivist interacting with the remote doctor. You need to have a dashboard that allows you to do that. And there are various technologies that make this happen. And the reason why I'm stressing on this is we can always do a deep dive on technology, but there is a pretty serious perception about the technology, and this is published evidence in multiple settings, that there is a lot of clinical resistance to it. So rather than focusing on the technology as telecare providers, we should definitely focus on how the operational matrix and how the workflow matrix should be set up so that the care members at a hub location, say at SGPGI, are best tuned to support the spoke hospitals with a proper framework. So it needs organizational change and leadership where the care delivery is planned correctly and the workflows are the most seamless. It's not really the technology that actually is the center focus. Yes, the technology is important. Yes, the technology has to play a role, but it cannot be an impediment. It's an enabler. And on top of that enabler, should you have appropriate workflows and appropriate processes. So there is a lot of research that exists out there, and we have spent considerable amount of time going through. But in the West, what you'll find is there is a mixed outcomes data, both in terms of mortality and in terms of cost. You will have some Western literature that indicates the use case of tele ICUs is mixed. Now, the interesting thing is that Indian data is going to be very different from Western data, and we need to generate our own data, and I'll share some of that with you. It is almost impossible to find clean mortality benefit from US data because their foundations are different. The impact that the tele ICU will have on US settings are different. But just look at the penetration of technology compared to India and the US. It's just dramatic. Take a moment to take this slide in, because this is where we are starting off. So if you're starting off here, it's actually unfair to use Western data and extrapolate it to Indian outcomes. This was 2 years. This paper was published 2 years after the first tele ICU went live in the US in 1998 in the VisiQ group. That's out of Johns Hopkins. And then the lead author here is Dr. Rosenfeld, who was Brian Rosenfeld was the guy who actually set up the first US tele ICU in 1998, which was later bought by Philips in 2008, actually. And interestingly, some of these messages are still being discussed. And I think what we as a group in India need to move forward is that we need to identify keys to success in our setup, explore those keys of success, look at those metrics, and just expand on that, because the use case has already been proven. We don't need to reinvent the wheel in that respect, and that's where we are losing a lot of time. So frugal innovation in our setting is going to be the game changer, where we focus on the functions, we reduce the cost, we definitely reduce the complexity, in the sense that when you're running a tele ICU in the West, most people focus on how to connect the device, what sort of jacks to use, what are the frameworks that are needed. We should change that. Just like the US was spending a lot of time in looking at how to use pagers, a pager system in the hospital. India completely leapfrogged that. Nobody in India uses pagers. So similarly, when it comes to tele ICU, we should not spend too much time, money, or expenses on copying that model. We need to devise our own model. So what you will need is you will need to drop the barrier to look both at the service and the technology, not in isolation. And this is a key message. Too often, healthcare technology companies focus on the technology. One of the key takeaways that we learned while doing this in India is that it's an 80-20 rule. 20% of your effort should be on the technology, and that technology needs to be the best in the world, designed for India. And 80% of the focus should be on workflows, training, and upskilling. That is the only way you'll be able to succeed in the tele ICU space. And that is what we as a group stress on as well, where you connect, you make a scalable system, you lower the barrier. Then you spend time on digitization and training and workflows. That is your key to success. And in subsequent lectures, as Professor was mentioning, we can go into details of how to do this. What are the nuts and bolts? How do we devise a workflow? That itself is a topic that takes hours to cover, because it is more an operational and a management topic that is related to tele ICU. Yes, it has connections with technology, but it is operationally dense. So just to give you a glimpse of how complex it is, this is how a day in the Tele ICU or a Smart ICU workflow goes. You need technology to assist you to get the data out. You need to do detailed reviews of the patient. You need to streamline on all the documentation so that all of this actually comes to the intensivist and the critical care team. And then you need an empowered collaboration between the two groups. There are a lot of egos. There are a lot of practice changes. There's a lot of equalization of practice that is required. And then you need to be sensitive that in India, some of these things need to be very mobile centric and not workstation centric. So these are very complex things that we are trying to break down, but I just wanted to give you an idea of what a day in the Smart ICU in Bangalore looks like when we are deploying this in many of our sites. Then as you go on to the next level, you're going to think about a virtualized care network. And a virtualized critical care network is more complex than a standard telemedicine network because it's minute to minute. It's supposed to be 24/7, and you need to have access to standardized care and highly trained doctors and nurses to make this a reality. But it allows a leading team, for example, at SGPGI, to scale to multiple areas quickly. And that scale I'll share with you because there are a lot of lessons in COVID that can actually be applied to what is happening today. So while we were active before COVID, some of the things we learned, in fact, will help large networks get set up very quickly and in a very scalable fashion because, one of the challenges is that we don't have enough intensivists. So if we have anesthesiologists or medicine RMOs or even MBBS doctors who we can support, that intellectual capacity of an ICU team can be disseminated to a much larger framework. It doesn't mean that an ICU can be run without a doctor. That's not the message of a Tele ICU. The Tele ICU is a augmenting tool. It's a complementary tool. You're not replacing doctors. You're just allowing doctors to function more efficiently with a higher level of productivity. That's what we are trying to do. So, for example, in a pandemic, our up and running time was between 5 and 7 days, as long as the government hospital provided us with internet and with power. All the other things we had to quickly deploy. We did not have time to hope for the perfect software or hope for the perfect milieu to make this happen. And that is why we also stress on training. And I was so glad to see the previous speaker also speak about training. And as a Tele ICU provider, we realized that this 80-20 rule that I was talking to you about, the 80% also talks about training, also talks about upskilling. So we partner with a government organization called IHMR, which is based out of Bangalore and Jaipur, to actually run a course like this that allows the upskilling. So before we summarize, I can share some Indian data with some of our government hospitals that we actually worked with during COVID. Here we've plotted the Apache score along with mortality, and we have seen this trend in multiple settings. This is from rural Maharashtra. The previous one was from northern Karnataka. And you see these trends over and over again in many of our government sites. And this is because not that we did any complex stuff and ECMO and higher forms of ventilation. This was just improving the accessibility to standard ICU bundles. Simple prone ventilation, appropriate oxygen, standard prophylactic bundles like DVT and stress ulcer prophylaxis. These things go a long way when you're stretched for resources in some of these government sites. This is a scale of the deployment, and some of this data is actually submitted for publication in journals. We were able to deploy all of these sites over the space of the pandemic, and we've now seen more than 4,000 critically ill COVID patients. So these are not ward patients. This is a database of 4,000 ICU patients that we took care of, and in these diverse settings from Leh to rural parts of Maharashtra and Karnataka. Like I was sharing with you, you need Indian data to understand what the Indian context is. So some of this is the only Tele ICU related eCPR data or Tele CPR data, where a remote intensivist ensures that the bedside is able to follow ACLS and BLS principles according to standard published AHA guidelines. This was a Tele CPR pilot study that we published with just 25 patients. Now we have a data set of about 700 CPRs that our Tele ICU team has monitored, and that also is being prepared for publication. not just from the core critical care space. If you have a network that has all the data on one platform, you can even look at antibiotic prescription practices. You can look at antibiotic stewardship concepts that can be plugged into your Tele-ICU framework. So for an academic institution and for critical care academicians, data collated on a Tele-ICU platform is very, very valuable from a practice change perspective. So we looked at antibiotic use in our surgical ICUs to enhance how we can actually improve their compliance with standard bundles. Interestingly, looking at remote monitoring, it is a key area where you can actually make sure that the patients who can improve and can heal at home should be given an opportunity to do that, because that is where their recovery can be very, very smooth compared to the delirium and risk of infection that they may be subjected to in a standard ICU. So that is also some work that we have done, and trainees can actually take this as a opportunity for research and training going down the line. So some of the future directions.
I have to interrupt you. I have to interrupt you, Dileep, because the time has come. So
sure.
There's some questions we have to take up actually. So allow some time for the attendees. So your slides are already be loaded in the YouTube. So the remaining slides also can be seen by the attendees. Okay. And my request attendees, kindly ask your questions through either way through chat, or you want to ask question, better to put on chat. You can manage easily.
Yeah, please go ahead. Happy to take questions.
Okay.
So one of the questions was, doctors posted in remote areas need super specialty opinions. This is exactly in line with what a Tele-ICU can do, because once you plug it into a Tele-ICU framework, you can get neurology, nephrology, cardiology, all the specialties that you are looking at can be plugged into this pervasive model of getting subspecialty care. The other question is second to monitoring getting critical information, quick decision support, how to overcome the high expertise and skill gaps. So that's exactly what I was talking about. We have to stress on teaching, upskilling, and training as part of the Tele-ICU model. It cannot be in isolation. And this is what we also do in our network. We do upskilling and training. We have our nurses and doctors going remotely to help with that. And at the same time, we have to focus on the interpersonal aspect so that the people who are getting upskilled can actually use the framework to in fact take up that and improve in their skills so that they can best utilize what is available to them.
Okay, so any other questions? Please put on the chart. Okay. I think we should think about training part. That is, you have highlighted that you have already associated with some institutions for training. But what is more important is while you deploy a project, so you must have encountered one part of the training which is very important for us, that you train a group of people, then in government systems, they kept transferred. The nurses get transferred to another ward. They, like in the ICU nurses, they can go to the surgical ICU, they can go to any other neonatal ICU, or they can go to operation theaters. So how to face this challenge that you train a group of people and they're kind of going somewhere, so how to train them? New batch. So don't you think you face a problem like that?
Yeah, you have to keep doing it, Professor. I think, the nursing transition and doctor transition needs to be factored in while your training program is live. So just like you are planning to repeat the training program in 3 months, we have a similar policy where we repeat the training program for new nurses and doctors in these sites so that they are continuously upskilled. That's very vital.
One question has come from Mr. Archit Pandhari. How well Tele-ICU cost?
Yeah, the Tele-ICU cuts cost in two major ways. One is in remote areas. One of the only things that patients have is they need to move to a bigger city. And immediately their per day costs in smaller ICUs is transition to a corporate ICU cost, which is very expensive for them. And as domain experts, any intensivist will tell you that as long as we have access, many of these conditions that do not require advanced interventions and only require supportive critical care can be managed in small to medium-sized ICUs. Thereby, a patient who is in Muzaffarpur or in Motihari does not need to drive to Patna, where their per day ICU bill will go up by 2 to 3 times. So this is one way where it definitely cuts costs for many of the patients that we have helped, and they're able to manage and stay with their own family locally. The second way it cuts costs is that some of these high intensity interventions can actually be carried on earlier, in the sense that everybody in an ICU would know that the golden hour or golden 6 hours is critical for appropriate treatment. If you do things at the right time in the initial part of their illness, when they present to the tier 2, tier 3 hospital, in fact, actually cuts costs for them, because effective therapy has already been instituted at the right time.
Dileep, I want to introduce you to Dr. B.K. Behra. So he is the Chief Medical Officer of NTPC. NTPC also has deployed Tele ICU. I do not know which agency is handling that. So, for them also, for a PSU, so they used to really spend a lot of money in sending their patients to different locations. But now they are being managed by their own kind of projects at Tele ICU and connected to some leading hospitals. They have been supported there. So this is very important, that many of the PSUs are also taking up for Tele ICU thing. But if you can do a good cost analysis and put it to the government, I'm sure the government will expand this network.
Absolutely.
Like currently the government of UP is setting up a Tele ICU project for only 6 medical colleges. I'm sure the government of UP is setting up 50 odd medical colleges or 70 odd. Every district will have medical college. We need to have such kind of network in place. Next question is Sudha. Training by AR, VR, MR technology will definitely give a better support in telemedicine. I mean, what I mean to Tele ICU, telemedicine altogether. So Dileep, you can take up as the last question.
Yes, this is true. And interestingly, we are looking at AR tools, not VR tools. We are looking at AR tools, because that really helps in teaching the nurses and doctors at the bedside about, say, using a ventilator device. So we combine the bedside tool with the augmented reality experience. And we've actually done an internal pilot on this. I completely agree. These are the tools that are of the future and need to be enhanced and encouraged.